Hello, my name is Mary Mitchell, and I'll be doing my clinical case presentation on Mrs. M.D., a 65-year-old Caucasian female admitted for syncope. History of present illness. Mrs. M.D. states she had a cough since Sunday. On Wednesday, she decided to go to the day and night clinic to get it evaluated. Once at the day and night clinic, she stated that she felt bad and wanted to go to the receptionist to let them know. Once she was at the receptionist window, she stated she needed to lie down and remembers waking up to a horrible smell and people standing over her. She states that they helped her get in a wheelchair and checked her blood pressure. She states it was 50s over 30s, and she passed out again. She was transported to the nearest emergency department for further evaluation. Her medical history is significant for hyperlipidemia. Family history: her father does have coronary artery disease as well as hypertension. Her mother has valvular disease requiring 2 AVRs as well as a AAA. Her social history is negative for smoking, but does report that she does drink on occasion, about once a month at social events. She also denies using any recreational drugs. She denies taking any home medications, including over-the-counter medications and herbal supplements. Review of systems. Mrs. DM does report being fatigued lately, but states that she started her exercise routine up again, which is 3 to 5 miles 4 days a week of walking. Her HEENT denies any blurred or double vision, denies any change in hearing, but does report that she has a sore throat from her cough. Neuro, she denies any changes in memory or any memory loss. Cardio, denies any chest pain or palpitations. Respiratory, denies shortness of breath, but states she does have a hoarse cough for the past 5 days. Non-productive. Musculoskeletal, denies any decreased range of motion and any weakness. Physical assessment. Vital signs are as follows: temperature of 98.8 oral, blood pressure of 107 over 46, respiratory rate of 18, heart rate of 57, sinus brady confirmed with an EKG. She did have a CBC, a BMP, and a thyroid panel, all of which were within normal limits. She had a chest x-ray that showed no acute findings. She also had a CT of the head, which showed no acute findings. Her HEENT pupils were equal, round, reactive to light. No JVD was appreciated. Neurologically, she was awake, alert, oriented ×3 with no unilateral deficit or ataxia noted. Cardiovascular, S1 and S2 were noted with no murmur, gallop, or extra heart tones appreciated. Bilateral radial and DP pulses were +2. Respiratory. All lung fields were clear to auscultation. No wheezes, rhonchi, or rales were appreciated. Musculoskeletal. Strength was 5 out of 5 to bilateral upper and lower extremities. Problem list. The first thing I would do would be rule out cardiovascular syncope related to any brady or tachyarrhythmia. Number 2 would be rule out reflex syncope related to a vasovagal response or orthostatic hypotension. Third would be to rule out seizures. And fourth would be to rule out a posterior circulation stroke or subclavian steal. Plan. I would place the patient on telemetry monitoring and repeat a 12-lead EKG in the morning to assess for any episodes of arrhythmias overnight. Second, orthostatic vital signs to rule out orthostatic hypotension. Third, blood pressure readings from both arms to assess for subclavian steal. Fourth, a 2D echocardiogram to assess for cardiac function and for presence of valvular disease. Fifth, would order a tilt table test to rule out vasovagal syncope. Sixth, an EEG to rule out seizure activity, though the patient states when she did pass out, she did not lose any function of bowel or bladder. You still don't want to miss a neurologic event. Seventh would be to order an MRI to rule out any CVA, although the CT of the head came back normal. If it's an acute CVA, it may not show up on a CT of the head, but it should show up on an MRI. Thank you.